So today, this is a podcast about neuroanaesthesia in relation to subarachnoid hemorrhage, and I've got a very special guest joining me. I've got Andy Lindberg, who's an anaesthetist. Andy, thanks for joining me.
My pleasure, Oli. Thanks for having me.
Do you mind telling people a bit about who you are and what you do?
My name's Andy Lindberg. I'm an anaesthetist at Royal North Shore Hospital in Sydney. I have a few interest areas, namely neuroanaesthesia, for which I've done a fellowship at Vancouver General Hospital. Other interests include environmental sustainability, and I'm involved in that area, and also I am involved in the anaesthetic allergy clinic at Royal North Shore. So I wear a few different hats.
Well, thank you so much for joining me, and you're the perfect person to talk about this sort of stuff, which is the kind of anaesthetic that gives a lot of trainees a nightmare, I think. Would you agree? Or?
Certainly. People get very worried about the minutiae in it, and understandably, the anaesthetic is very important to the patient's outcome, and there's a lot of ways that we can influence that outcome, and I think it's valuable that we consider it.
All right, let's talk about a case. So let's imagine it's 10 o'clock at night, you are on call, and you get a call from the neurosurgical reg to say that there's a WFNS grade 5 subarachnoid ED with a high fissure for blood load, and they want to take them to theatre to put in an EVD, even before we do a DSA and work out exactly what kind of aneurysm we're dealing with. What is going through your mind when you get that call?
A lot's going through my mind at that time. Obviously, it's 10 o'clock at night. You've got a very sick patient who's got a grade 5 subarachnoid hemorrhage. So there's a lot of associated complications with that, but they also need emergency surgery and an EVD, presumably for evolving hydrocephalus, and they need some CSF drained and also to be able to monitor their ICPs. So my assumption at that time of night is that I know very little about the patient other than their disease process, and I'd be trying to get more information about their underlying physiological status, how the disease is affecting them. I'd be very interested in looking at the imaging at the time that is available, understanding that ultimately they're going to have a DSA to actually visualise the aneurysm and its rupture. But things I'm concerned about at that stage is, their airway management. Presumably with that GCS, they're going to be intubated down in ED, or they're going to need intubation, certainly for the EVD, and I probably want to be involved with that. The other things are clinical manifestations of the subarachnoid hemorrhage, whether they've got some cardiac dysfunction, electrolyte disturbances, whether they have underlying anticoagulation in their history, things that I can modify rapidly or need to think about managing. And then it's about, efficiently getting them to theatre, not crashing into theatre in an uncontrolled manner, but doing things in an efficient manner to make sure that that patient is managed appropriately in an efficient manner.
Yeah, fair. What's different physiologically for this patient compared to a routine neuroanaesthetic?
So the assumption is that they've got raised ICP based on their clinical status. So in terms of their cerebral perfusion and their cerebral autoregulation, my assumption is that that is disordered, and that I'm not going to have the standard buffers in place for a healthy brain that will buffer any significant swings in their blood pressure, and that I'm going to need to manage that accordingly. I'm concerned about their cerebral perfusion pressure in general, and that they're getting blood and oxygen to their brain. And I'm also concerned about re-rupture. They've had a rupture, and I'm concerned about that occurring again. They've managed to make it to hospital, but they may have a rupture at any point. The disease is systemic, so it's going to affect other organs, and I'm concerned about their cardiac function, whether they've got Takotsubo's, the ECG, they might have QT prolongation or ST depression. They also might have electrolyte disturbances.
Okay, Andy. So if you're called down to ED to assist with the intubation, what do you want the setup to look like, and what are you thinking in terms of helping make sure this goes as smoothly as possible?
So this is a critical airway that we've got to deal with. We've got a very sick patient that we need to think about a range of different things. The main physiological parameters that I'm thinking about is avoiding re-rupture with the stimulating laryngoscopy and intubation. I also want to maintain their cerebral perfusion pressure. So that's MAP minus ICP. So I'm thinking about kind of my systolic goals in that. I might be aiming around systolic of 140 to 160 in this patient. And I also don't want large swings in their blood pressure to maintain their cerebral autoregulation in that period and also avoid re-rupture. I'm thinking about their ICP. So I want to avoid big increases in their ICP, and I also want to get their ICP managed. This patient has a low GCS by their WNF-FNS score, so I can assume they're probably reasonably obtunded. Their arterial CO2 is going to be elevated, and that's going to be bad for their ICP. I also want them sitting head up a little bit, and those ICP management considerations to be considered. This patient's probably unfasted. They've probably got a full stomach. I'm thinking about doing a modified rapid sequence induction and getting the tube in reasonably quickly. They're kind of my goals for this. Some neuroprotection to facilitate transfer up there. So the way I'm going to think about achieving that is obviously I'm going to observe them, see how obtunded their airway, see if there's vomited everywhere. And it's really an ABC approach, looking at their airway, breathing, circulation quickly to see what needs to be done urgently. If I think their CO2 is 70, their arterial CO2 is 70, or they're hypoxic, then that's going to be terrible for their brain. I'm thinking about doing this very rapidly. If I feel like those features are well maintained, then I might do things in a bit of a more controlled manner. Where I might consider a pre-induction arterial line, but if I think they're very obtunded and they're going to get worse, and I think I need to do things more rapidly, and I'd be thinking about minutely cycling of their blood pressure. In terms of how I'd set it up, so this is in terms of managing their airway and intubating them, I'd make sure I had good peripheral access, and I'd be thinking about having a peripheral vasopressor infusion, whether that be metaraminol or phenylephrine, or possibly a dilute noradrenaline infusion. In all these situations, you often don't know much about the patient. They've often arrived from outside and you've got limited information. I'd try to make a quick assessment of their cardiac status, their volume status, whether they've got pulmonary edema or neurogenic pulmonary edema from the subarachnoid hemorrhage, but all those things are going to be done reasonably quickly. And then I'm going to have an experienced airway operator with a video laryngoscope. I think would be my go-to in this manner, with adjuncts available, a bougie or a starlet on the tube, and adequate pre-oxygenation as best you can. In terms of induction agents, so really this is where you want to avoid big swings in the blood pressure. You want to avoid the stimulating laryngoscopy and avoid the stimulation of passing the tube through the cords. But you also want to maintain their cerebral perfusion pressure. So in ED, you've got kind of a few main options I would think about. Propofol, which might drop the blood pressure significantly, but is a very effective hypnotic and doesn't affect cerebral autoregulation as much as others. Opiates, fentanyl would probably be the go-to that I'd be thinking about there, but that needs a period of time to work. More experienced people with a significant amount of anaesthetic training, I suppose, could consider medications like alfentanil or remifentanil if that was there, just to really rapidly blunt the sympathetic stimulation. But I'd probably definitely shy away from those two medications if you don't have significant experience with them. Other options would be ketamine. People are concerned about that elevating the cerebral metabolic rate and potentially cerebral blood flow, but I feel like more recent studies have probably shown that that's not such a big deal, and it's got the big benefit of providing cardiac stability. So you're really going to provide the good cerebral perfusion pressure with that potentially, and ED might be very familiar with that. Another thing that we sometimes use in anaesthetics, which I find a bit more cardiac stable, is thiopentone, which we have access to in Australia, and I find that quite a good medication, and will probably be a better agent for maintaining what cerebral autoregulation you have that's remaining. The other thing to mention is that I really don't want this patient coughing or bucking. They're going to be well paralysed. It's also, potentially they've got a full stomach. So I'm going to be doing at least a modified rapid sequence induction with a generous dose of rocuronium, 1.2 to 1.5 milligrams per kilo as an intubating dose, and giving that a minute to work. And in that time, I similarly don't want this arterial CO2 to go higher than it already is. I'd ideally be aiming at arterial CO2 around 35 to 40 in this patient to reduce their ICP. But these are all tricky situations, and you do your best to manage these things. And once you've got a tube in and you can ventilate them more aggressively, then all these things are a bit more easier to achieve. Tube would go in, it'd be taped, trying to prevent any obstruction to venous drainage. I'd have the patient up at 30 degrees. I'd definitely be running a propofol infusion, maybe a fentanyl infusion at that stage to facilitate transfer, and I'd be ensuring that they're well paralysed for that transfer up to theatre or to imaging. And all the same, defending that cerebral perfusion pressure with a metaraminal or phenylephrine infusion. Ideally with those, I try not to bolus things. I try to titrate my infusion rather than just boluses.
Some people may not be as used to a phenylephrine infusion. How do you make up your phenylephrine, if you don't mind me asking?
So I also don't use it much, but 10 milligrams goes into 100 mils, and then I titrate it, 1 to 20 mils an hour is commonly how we do it here, but different centres do it differently. Might do a weight-based. It's very common in North America.
Yeah, right.
I believe.
And what's your take on lignocaine?
So I think lignocaine is a very good adjunct for intubation. I think it blocks the sympathetic response to laryngoscopy quite a bit. So I often use it as an adjunct, 1 to 1.5 milligrams per kilo. But I would also be using an opiate in that time. Yeah. So something to mention with the fentanyl is the fentanyl takes, and lignocaine as well, takes 2 to 3 minutes to really reach its peak effect. So I'd be giving those early.
And dose-wise with your fentanyl, are you using like 3 mics per kilo, sort of a fairly big dose to blunt it?
Yeah, you need a fairly big dose to blunt the stimulation of laryngoscopy and passing the tube. So yeah, I'd be looking at least 3 mics per kilo, maybe 5 mics per kilo, depending on the robustness of the patient, and I'd be giving that a bit of time to work. Other things that people sometimes use are beta blockers if they're tachycardic, to bring the blood pressure down. So medications like esmolol, you could give labetalol in advance. Esmolol is a more commonly used one to try and blunt that, but I'd probably shy away from that in people who aren't experienced with it. That would be my preference.
And have you ever run into trouble with giving a big dose of fentanyl and planning to wait for 3 minutes, but then they lose their airway and things get a bit different?
Sure. So you've got to adapt. And if in any situation, if someone starts aspirating, then you've just got to get the tube in as quickly as you can with suction. And I should have said that I'd definitely, in theatre or in ED, I'd make sure that I had suction available. The other thing to consider in these cases, often in theatre, people will kind of do a test laryngoscopy. So they'll put the laryngoscope in the mouth and see what sort of hypertensive response or swing that got before they go to pass the tube. But that response might develop a minute after. So I think in ED, especially if you've got a compromised airway with where it's all changed and they become completely obtunded or aspirated, then the concept of test laryngoscopy is out the door, and you're not going to do it in that instance. But if everything's stable and in time, then you could potentially do a test laryngoscopy and check that you've blunted everything with a decent dose of fentanyl. If you haven't, you could give more fentanyl or more propofol. Propofol also does the same thing.
So the main things are basically predominantly prop and fent based induction agents, good dose of paralytic, lignocaine to blunt the airway reflex, the best operator available, a video laryngoscope so you get the best view and you don't have to manipulate as much, and maybe a bougie first up so you get it in first time and you're not messing around. Would that be a reasonable summary?
Sounds like a good plan.
And you've been talking about systolic targets. Why would you go systolics rather than map targets in this context?
Look, I just feel like I don't have a particular reason other than it's just easier and easier to kind of assess and do. The rupture is, if it was to re-rupture, then it's a combination of the map and the systolic and the variation in that. But I just find systolic easier to
it's the common language that we usually talk about it in, but in some ways it makes more sense to talk about maps, because underdamping and overdamping can mean that your invasive systolics are a bit less reliable maybe, but you're right. It is just the common lingua franca, isn't it, to talk about map targets. It's what the neurosurgeons talk to us about. I notice a few guidelines are moving towards map targets now, which I can see the rationale for. Yeah,
certainly, especially with an outline in situ, then your map is definitely more reliable than a systolic. I acknowledge that feedback. It's probably a very reasonable consideration, but I just don't necessarily have the map targets in my head so easily.
Yeah. No, I know what you mean. Okay, so you're talking about infusions. Would you actually have both an aramine infusion and a labetalol infusion running together and just be upping and downing them as you go, or would you wait and be reactive? How would you actually do it practically?
My hands, I'd have a metaraminol infusion running, or phenylephrine in other parts of the world, but I routinely wouldn't have a down. Propofol or fentanyl or alfentanil would be my downer of choice, and it's rare not to be able to achieve the upper limits of blood pressure targets with those medications.
And then it's back up, you'd have vitralizine or labetalol as an option, right? Or
esmolol, which is very short acting and rapid onset, if their heart rate allows, and their heart rate's the problem. In some parts of the world, they might use calcium channel blockers, but at our institution, that's uncommon for us to use IV calcium channel blockers, but it's certainly something that you could consider.
Yeah, for sure. Now, you mentioned rock rather than sux. Why would you go rock rather than suxamethonium?
I think the theoretical risk of suxamethonium and increasing ICP and having a long-term issue in this kind of patient is essentially irrelevant. So I think suxamethonium is a reasonable choice if that's your preference, but this is a one, so to speak, a one-way intubation. I'm not looking to wake them up, and certainly if I struggle to get the breathing tube in, I'm going to continue down an algorithm, let's say the vortex, and I'm not pulling out. I'm not going to be thinking about reparalysis. I'm going to be looking to do front of neck access. So I think rocuronium is a better agent in that regard. Gives you time to do things. It's also got rapid onset, whether that's 15 seconds longer. I haven't had an issue with that time course. And the idea of drawing up Sagamidex to reverse them, I think is probably impractical and not something that I'm going to do in that scenario.
Is there ever a role for awake techniques?
Yeah, look, there certainly is. I think if if you think you're not going to be able to bag mask ventilate someone and you think you're going to have trouble intubating them, then I think your arms are tied behind your back. Whether I do that in D or not is a different story. I might try and move them up to theatre where I feel a bit more at home.
Yeah.
But I certainly don't want to be attempting multiple laryngoscopy attempts in this patient and having their blood pressure go everywhere and then ultimately doing a front of neck access and completely losing sight of my hemodynamic requirements for this case. So with good topicalization, and I'm probably more inclined to do something asleep and bag mask them. But yeah, I think there's always a role for an awake technique.
But that would be like a 1 in 1,000 rather than...
I haven't encountered it. But
never. All right, quick hot takes on this area. Is smooth induction overrated mythology or genuinely critical?
I think it's genuinely critical. As an anaesthetist, I think it's something that we can achieve, and it's somewhere where we can make a real difference. If something ruptures and it's due to our laryngoscopy, then I think that's avoidable, and I think it's in our wheelhouse that we can facilitate that. And so I think the real danger with rupture is big swings in blood pressure, whether that be up and down or up or down with induction and then up with laryngoscopy and then down afterwards, and then you end up bolusing them. Those large swings in blood pressure have a big effect on transmural pressure, and you really risking rupture every time. And re-rupture, as we know, is a terrible outcome.
Yeah. All right. Which matters more, avoiding hypertension or avoiding hypotension? I'd say both.
Well, as I've said, I don't like swings. I think ultimately hypotension is worse. I think watershed infarcts and cerebral ischemia is something that we can avoid. And I think the patient who's hypertensive and with a GCS of 15, they're obviously maintaining cerebral perfusion. Overall, I think that sustained periods of hypotension are worse. I guess the caveat there being where if you're intraoperative and it's ruptured, then I'm
right. Yeah, you actually have a rupture. Yeah.
Then I'll accept a period of hypotension for a period of time to allow a clip to go on.
Right. What kind of BP drop during induction really makes you uncomfortable? Like how much is sweaty?
I'd say anything greater than, if we're talking systolics, it's more the rate of change, I think, that worries me. If someone's gone very rapidly from a systolic of 160 to 120, I'm going to presume that that's going to continue. So I might be worried about that rapid change at 20 millimeters of mercury. But if someone's just slowly trended down from 160 to 120 and then kind of plateaus there, I'm less concerned. But anything over, if someone starts high, then I'm getting concerned at any drop over 20 millimeters of mercury, and I'm starting to think about ways to augment that. And
TEVA, is it just evangelism, or should it be the only thing we use in this context?
Look, it's evangelism at our institution, but I think it is. Yeah, look, I think TEVA has a role, but I think people lose sight of the end goals, and however you're going to achieve that, you want to avoid re-rupture, you want to maintain cerebral perfusion pressure, you want to achieve a good accessible wake up at the end of that, and that can be achieved many different ways. And whether that's with volatile and a bit of remifentanil, propofol and remifentanil, people achieve it very different ways and with good outcomes, and there's no evidence that preference is one over the other. Propofol has the advantage of not inhibiting cerebral autoregulation like volatiles at higher MACs are, but at a lower MAC of volatile anaesthetic than which most people would run for these kind of cases. It doesn't impair cerebral autoregulation, and it's a very safe choice in many people's hands. So I think at our institution, anaesthetists will exclusively use TIVA, but I think that's probably unnecessary. We do also have the advantage of TCI infusions, which I'm not exactly sure of the state of play in North America, but classically they haven't had access to them. They may be starting to gain some traction, but TCI I think is a wonderful addition, and so ultimately at our institution we use TIVA pretty much exclusively for these patients, so as not to unnecessarily increase cerebral blood flow. The outcomes can be achieved either way.
Nice, good answer. All right, let's say you've done the perfect anaesthetic and the patient gets their EVD and they are then still intubated and sedated. They then go for a DSA, and the DSA shows that their aneurysm is more suitable for clipping than for coiling. We won't go into the details of that decision making at this point. And so now you're doing the anaesthetic for the clipping. How does clipping differ from coiling physiologically and technically when you're doing this second anaesthetic?
So the main differences are the location. So I guess coiling is often off the floor anaesthesia, so you're more remote and isolated. And you have impediments like lead and a imaging machine and so forth that can make access to the patient tricky. But in terms of the physiology of it, the main differences are that for clipping you need brain relaxation, and that requires different interventions for the surgery, for the surgical access. So we consider things like mannitol or hypertonic saline to achieve that. And other than brain relaxation, you've got considerations like more likely to bleed, and you're going to make preparations for that. So in this patient who has a lot of blood in their brain already, you're going to assume that this is going to be tricky to clip, and it's going to be tricky surgically, and that there's a reasonable chance of re-rupture intraoperatively. And so I would be anticipating that there's going to be some blood loss, so I'll be cross-matching some blood. Whereas coiling, it's a closed space. You've still got the same considerations around ICP, but you don't need to achieve the brain relaxation. You don't need to, you're not so concerned about blood loss, but you've got other considerations like anticoagulation, which might be administered during a coiling and how that might impact things down the track. If they go to an operation, you might need to reverse it. Clipping their head is going to go into, there's other points of the operation that are very stimulating. So the placement of the pins can be very stimulating. The actual surgery and the dissection of muscles off the bone can be very stimulating. So different points of the surgery can cause a sympathetic response, and these you need to preemptively manage. In terms of access, because of blood loss, I'm going to make sure that I've got a good peripheral intravenous cannula. In these kind of cases, I would routinely put in a central line. I know that's controversial in some instances, but I think it certainly allows me to give medications quickly. And if it ruptures, then I'm going to be thinking about what medications I can give in that instance. And also I think it's a courtesy to you in RCU to have that post-operatively, this is going to be a patient that's going to need a long duration of IV access, and also you'll be giving a range of medications through it. And I'm thinking about positioning in terms of the pins and how the patient's going to be positioned for the surgery, and how that's going to affect my anaesthetic.
You mentioned rupture. This is the sort of thing that gives everybody nightmares. Can you describe the operating room when a rupture happens?
I would say it's universally tense, but my experience with it, it's always been calm. We're very fortunate to have experienced neurosurgeons and very good neurosurgical operators that I've always had the pleasure of working with. So I'd say it's invariably calm but tense. Suddenly the sound of the high volume suction increases, and you might be watching a canister fill with blood. The anaesthetic machine might start alarming for changes in physiological variables that you need to manage. They might drop their blood pressure, and things that you need to be aware and manage. So certainly the vibe does change, but invariably, it's been calm but tense.
And what are the first three things you do when a rupture happens?
So, look, I'm always watching. This is an operation where I'm always watching what the surgeon's doing. They've got a microscope and we've got a screen. The surgeon is completely engrossed in what they're doing. I'm not expecting them to give me updates, but I can observe it. I pause. I pause for 30 seconds. Most of these, they will get control in a short period of time, but I will let the surgeon know that I'm aware of what's happening. And in my head, I'm thinking about where this might go. So I need to be able to assist the surgeon in clipping it effectively. And the other arm is that this might result in significant blood loss, and I need to start thinking about that. So at our institution, we often use thiopentone to both drop the blood pressure and to reduce the cerebral metabolic rate and provide some brain protection. Might be controversial, but that's kind of our standard. So I'd be looking to draw that up and get that ready. The other thing to consider ultimately is whether we're going to administer adenosine, and I'd be starting to get that ready as well, and also having just other medications that could possibly bring the blood pressure down. In this kind of case with such a bad score, something I omitted to say before is I would definitely think about attaching something to bring the blood pressure down before we started, whether that be an infusion of sodium nitroprusside or that kind of medication. So I can also assist for a prolonged period of time.
What mistakes worsen rupture outcomes?
Good question. I would say if it's very hard for the surgeon to get control, if the surgeon can't get control, then you're on a hard into nothing. Without the surgeon getting at least a temporary clip on so that they can ultimately get a clip on, then it's only going to end badly. So ultimately, we have a role to assist the surgeon in achieving that outcome. And I think that would be the number one thing that would worsen outcomes. Prolonged hypotension. So while I'll accept a lower blood pressure for a period of time to assist them getting control, I don't want that to be for a very long time. So what that number is, I'm not sure, but I'm certainly cognizant if I'm allowing a MAP of 50 to 60 that I might be contributing to morbidity postoperatively, and I want that for the shortest period of time. But my objective is to allow the surgeon to get control of the situation. If you're going to allow the blood pressure to go extremely high, then I don't think that's a good outcome either.
Yeah, fair. What's your hairiest ruptured aneurysm experience? You don't have to say where it happened or name any names. It's all right.
No, it all revolves around the duration of time to get control. Really, the longer the rupture goes on for, the more the surgeon is battling, the worse, the likely worse outcome. So however far you work down that algorithm is where you start to get worried. And on fellowship, we would use adenosine far more liberally and early on. And at our institution, we very rarely do, and I haven't, and that's in conjunction with the neurosurgeons. But there's certainly been a case where we had a prolonged rupture in a patient who'd had a subarachnoid hemorrhage at the top of a crane as a crane worker and had to get extricated down from there. So it all took a long time for him to get to us, and it was a very complex aneurysm. They had a low GCS initially, and they then had a significant intraoperative rupture that took a long time to get control of. And the neurosurgeons were after lower and lower blood pressures, and it's a delicate balance. And the longer it goes on, the more you worry.
Yeah, right. And just for those who are not used to it, just explain how adenosine works in that context.
So adenosine is attempting to cause cardiac standstill, essentially. So it blocks the AV node for about 45 to 60 seconds. It's very rapid onset. Other clinicians would know it's used in SVT and interrupting that arrhythmia. But in this situation, it is essentially there to achieve a low blood pressure for a period of time that's reversible. So we'll administer 0.3 to 0.4 milligrams per kilo, often 24 milligrams, ideally through a central line. And we expect low blood pressure with the occasional escape rhythm for about 45 seconds. And that's the time period that the surgeon has to control it. One thing I will say, that this is a medication you need to give with the neurosurgeon being fully aware that you're administering it, because they've got a definitive window of time to
crack on,
do it. So you want them to be ready and know that it's happening, and not just give it blindly. So communication in these scenarios is key.
Essential. Yeah. All right. Let's switch over to coiling specific anaesthesia. Let's imagine the opposite happened and the patient is now in the angio suite having a coiling. We're in a scenario where they're intubated already, but if they weren't intubated, say it was a lower grade subarach, what's your take on GA versus conscious sedation for aneurysm coiling?
In my hands, it's always been a general anaesthetic. The proceduralist wants them to be motionless and to have control. And I understand that in some institutions they may do it with sedation, but you don't want these patients moving or adding to the challenge or getting agitated. They've got to lie flat for potentially a prolonged period of time. And from my experience, I much prefer to get the endotracheal tube in a controlled manner at the start of the procedure, when I've got my preferred access to the patient, rather than getting in when someone's on the angio table and needing to convert them to a general anaesthetic. I always find that much more tricky to achieve the end goals that we've spoken about already, that are still present in a coiling. So we want to maintain their cerebral perfusion pressure. We want to avoid re-rupture. We want them to be accessible afterwards. I find that much trickier to achieve in the midst of a coiling if the patient gets agitated. And the proceduralists at our institution prefer that as well, is my feeling.
And converting to a GA in the middle is a pain. So
it's tricky.
Yeah. What about you're doing the coiling anaesthetic, and the proceduralist says that they're getting vasospasm, and you can see it as well on the screen. How is that managed, and which agents are you using?
So classically at our institution, the proceduralist will manage that with intraarterial nimodipine. And I will let them do that, cognizant of the fact that will likely drop their blood pressure. And that's clinically what we see. So I'll be preempting that and supporting their blood pressure when they're doing that. So I'll be going up on my infusion, my vasopressor infusion of choice at that time, preemptively trying not to bolus it. We classically don't give systemic intravenous medications. I guess a discussion could be had around milrinone and whether we started that, but classically that started in ICU and we used nimodipine postoperatively. That I haven't started in theatre in my experience.
And they often use intraarterial verapamil or intraarterial meronone as well now, don't they?
Yes. Yeah.
There's not a lot of evidence to back either approach particularly, but has similar effects on the blood pressure in terms of like the dose of intraarterial meronone is one that causes quite a lot of hypotension associated with it, doesn't it?
Sure. So it's just about preempting those swings.
If they are doing a balloon assisted or a stent assisted coiling, what does that change for you?
So with a balloon assisted coiling, they are essentially occluding the artery. It's in some ways like putting on a temporary clip, and I'm concerned about collateral perfusion, and I might think about driving their blood pressure. From my experience, it's been short-lived. They're likely to request heparin or medications like that, and more the impact for that is that if it ruptures and they can't gain control of it during the coiling and they might need to come to theatre for a clipping or an EVD, then I'm thinking about reversing that heparin that I might have given. And that's one of kind of the main differences in that area. Other than that, I treat it much like other coiling cases.
Yeah. You've worked in a few different places. What separates a smooth neurointerventional suite from a chaotic one?
I think there's a few things. Communication is key, and that often comes with teams with experience where people know each other and have experience operating with each other. I think a shared understanding of what's going to be done and a shared understanding of the pathology between the interventional neuroradiologist and the anaesthetist, and to understand which ways the likely outcome of this are and how tricky it's going to be for the interventionalist. But I think ultimately it comes down to clear, concise communication in these environments that can be highly stressful.
Yeah, right. No, I'd agree with that. We've covered a few of the different complications like vasospasm and blood pressure swings. Cardiac complications we touched on a little bit. Rupture we've talked about. There are also things like sudden brain swelling, ventilation issues, electrolyte chaos or complications, pulmonary edema, and then patients not waking up well at the end. Which of these complications scare you the most?
Significant cerebral edema at the end of the case, I think, is a very tricky manage, especially if it's very significant. Ultimately, as an anaesthetist, we're always worried about someone who doesn't wake up appropriately, especially if preoperatively they had a good grade aneurysm, and you think that your anaesthetic would have had a great effect, and I guess that's the aim of it. So the complication of someone not waking up appropriately, where you think your anaesthetic may have played a role, if you weren't able to achieve adequate blood pressure throughout, or you had significant swings in blood pressure and there might have been a rupture beforehand, would be probably the most stressful complication. But that's really a multifactorial thing, a component of everything that's come before it. In isolation, intraoperative rupture is the most likely thing that we see that is potentially stressful.
Yeah, right. What near misses have taught you the most?
Well, I've had a few near misses. Early on, I drew up phenylephrine as I would metaraminol, when usually diluted in 100 mils as opposed to 10 mils. I didn't administer it to the patient. Unfortunately, the consultant or attending at the time noticed what I was doing, but that was in an aneurysm case. I'd never done something like that before. It caught me by surprise as well, but it was just careless. but it certainly taught me to be very careful in these kind of cases because the stakes are high. Later on in my training, I've flushed Sagamodex down a line that may have had some vasopressor in it, and that's caused significant hypertension and bradycardia at the end of a case, which complicates the procedure significantly. Whether that's a Cushing's reflex or the medication, ultimately they needed to go for a CT scan before we were confident that it was an anaesthetic error, so to speak. But these things really have taught me that you've got to be very diligent with these kind of cases and careful with what you do. It's not a crash into the room kind of emergency case. You have time to do things safely but efficiently and safely.
And they're genuinely fragile, aren't they?
Yeah, certainly are.
In terms of fast wake up or deep extubation, what's your go-to?
My preference is to have them awake when I remove the tube. I don't do deep extubation in these patients because my preference certainly is not to be re-intubating them and going through that process if they don't wake up appropriately.
Yeah,
we have the benefit of remifentanil, which I think is just a fantastic medication in these cases, where I will have wound back my propofol, or if I'm using volatile, I've wound back my volatile quite a bit before I'm removing the tube, and then my remifentanil is just decrementing over 5 to 7 minutes, and I'm constantly assessing the patient to see whether they open their eyes. The remifentanil pretty much universally stops them coughing or bucking, which I'm concerned about increasing their RCP with. And then when they're responding appropriately and they're opening their eyes and they'll take a breath on command, then I'll remove the endotracheal tube, and they're essentially awake and accessible by the neurosurgeons. So that's kind of my preference.
When do you keep them intubated? Which context?
So I think a patient that has a low grade 4 or 5 WFNS subarachnoid hemorrhage prior to any intervention is going to stay intubated. I've never figured out how to do an anaesthetic that's improved someone's GCS, so I assume that my anaesthetic is going to lower the GCS. Someone who's very agitated beforehand, very distressed or confused, and is going to be very difficult to manage their blood pressures postoperatively, then I might consider in discussion with the neurosurgeons. Someone who's had a prolonged course of a temporary clip, or these are always discussions with the neurosurgeons. The neurosurgical preference is usually to wake them up and make them accessible. But if I think there's going to be benefit in keeping them kind of flat and for a period of time until things just settle a little bit, then that's a conversation I'm willing to have. But usually most of the ones that we keep intubated come with a low GCS to begin with, and I don't think that's going to improve, or they've been intubated off-site and I've never managed to see the patient preoperatively, then I'm more inclined to leave those ones intubated. Does that sound reasonable?
Definitely, yeah. Your antiemetics of choice, if they've got nausea and vomiting and post-operatively, what do you go to?
So, ideally non-sedating antiemetics, but there's few of those. These patients who routinely get dexamethasone, they pretty much routinely get ondansetron. I will have looked at the ECG and seen if there's QT prolongation. And ondansetron may lengthen that, but I haven't clinically seen a problem with giving it, and they're in a very monitored environment. Dexamethasone or ondansetron would do the bulk of the work. Other antiemetics of choice would be sedating and might cloud your assessment after, so things like droperidol or cyclizine. The advantage that we've got as well is that we've used propofol to do the bulk of the work, and that's also an antiemetic and less likely to cause postoperative nausea, vomiting. So that's one.
That's some heavy
to
lifting.
support that, yeah.
All right, I'm aware of time, so just a few final questions, if you don't mind, to squeeze out of you. You've been so good, so thank you. What's changed the most in the last 10 years of neuroanaesthesia in this context?
Definitely, I think the advent of neuroradiology interventions has grown significantly and been supported by evidence. The amount of aneurysms that are done by coiling now in facilities that have access to it has grown a lot, and the aneurysms we see for open clipping has reduced. And in some ways seem, well, actually the neurosurgeons are far better placed on the technicalities of it. Sometimes we see very complicated aneurysms for clipping, and sometimes seem to be less complicated neurosurgically. All have their risks though. But that's been the bulk of it. And as anaesthetists, we've had to become very familiar with being in the interventional radiology suite and the challenges that provides. And the radiologists have had to become very comfortable with us having us in the room and the challenges that provides for them. So it's a shared model.
Nice. Which old dogma in neuroanaesthesia should die?
Dogmas can be very institutional in this area. In our institution, we almost routinely put in central lines for these cases, whether they're ruptured or unruptured, elective or urgent. Whereas other institutions, I know internationally, very seldom put in central lines for concerns about impeding venous drainage. And I think any dogma like that is probably incorrect, and the truth lies somewhere in the middle. I feel like there's certainly elective aneurysms that don't require central lines that we might put in at our institution. And then I think there's patients that certainly benefit from having them and in their long course in hospital. I don't know how you feel about it in ICU, but I do feel like
they're
they
always
also
helpful,
have them.
But they're always helpful. But I totally realise that they're not necessary in a lot of patients. So yeah, no, I get that. All right. What do trainees focus on too much in this sort of context?
I think I alluded to it earlier. When people lose sight of the goals, trainees in particular get very bogged down in the pharmacokinetics of the medications and which medication will achieve this exact outcome, whether that be TIVA, for example. At our institution, I would say trainees can certainly get fixated that that's the only way to do this kind of case. But I think ultimately you need to understand the goals of the surgery in aneurysmal surgery, and that can be achieved multiple different ways, and there's different ways to skin a cat. So I think trainees just need to see the bigger picture, and rather than that minutiae, be kind of preempting where the surgery is going to go and have plans in place for the different ways that it might go.
Yeah, I like that. All right, can you give one tiny detail that separates elite operators from average ones?
I've had the privilege of working with a lot of elite operators. What definitely stands out is they universally seem to be one step ahead. They've assessed the imaging. They've made their own risk assessment of how tricky this is going to be for the surgeons, how likely it is to rupture, and they've scaled their anaesthetic accordingly.
Mm.
They've noticed things like blood pressure swings at the start of the case when they're inducing, and how that might impact their wake up, and how they might preemptively treat someone for hypertension at the end with labetalol or hydralazine at the end if their blood pressure didn't drop in a standard manner at the start. If you induce the patient and their blood pressure is resistant to that, and it kind of maintains high, then at the end of the case you're going to have a problem where their blood pressure is going to be high, and preempting things like that. They're observing what the surgeon's doing and they're aware of the key points. This isn't a case where they're doing Sudoku or any crosswords. The elite anaesthetist, well, all anaesthetists in these cases should be watching what the surgeon's doing and aware of what's happening, but that's certainly what the elite ones are doing.
No Sudoku. Are you serious?
Yeah.
All right. And what should intensivists understand better about the anaesthetic challenges?
I think our relation. Yeah, I think the challenges for us are often that we don't know much about these patients. So this patient that's arrived at 10 p.m. at night, we don't have a clear understanding of their preoperative status or what they were like before they came in. There's a lot of kind of hearsay or coming from different people, and that may be reflected in the handover. We kind of deal with what is in front of us. Lines and so forth that we place usually with the consideration of the surgery and the challenges of positioning, and whether that's in a radiology suite where we have only access to one side of the body and one arm. It may not be in consideration of how the ICU nurses would like it set up. But I think overall, in these cases, my experience at our institution is that, you've been mostly understanding of the challenges that we face, and likewise, I would like to think.
No, I think we get on pretty well, which is good. Thank you. I think that's been a really interesting conversation, and I hope people listening to this will get a lot out of it. I think it's been really educational, so I really appreciate your time.
My pleasure.
Final thing, thank you for being part of the support for the International Subarachnoid Haemorrhage meeting we're having at the end of this year. What do you think is the main draw for anaesthetists to come to this meeting, and why should anaesthetists be interested in this one?
I think this is a fascinating conference. It's about a single disease, and this disease process is unique in many ways for anaesthesia. We're intimately involved across multiple specialties. We see these patients coming at 10 p.m. at night for, as you say, an EVD, or then going to the interventional neuroradiology suite. They might go up to ICU and get some management there, come back to theatre for a clipping, or DSAs we see at our institution along their course. And I think it's really important that we've got a shared mental model, and that we know what's happening across the specialties. There's a lot that we can learn from the neurosurgeons and the intensivists, and there's also a lot that intensivists can learn from anaesthetists as well. So there'll be seminars that are very valuable for anaesthetists and their neuroanaesthetic practice, whether you're a generalist and you might face this problem at 10 p.m. at night, or you're a neuroanaesthetist by trade.
Yeah, I think that's absolutely right. We've got 3 streams at the conference. So there's a surgical stream, there's an INR stream, and there's a crit care stream. But I think it's going to be really interesting if you're in crit care like we are, to go to the INR stream to understand some of those aspects more intimately, or the neurosurgical stream. And then there's also workshops. There's a survivors workshop, which will be really interesting, sort of working out the best core outcomes to look at. And they've got some of the sort of world leaders in outcomes from Subarach sort of defining outcome measures we're looking at with actual survivors talking about it, which will be really interesting. And then there's like a INR and imaging masterclass for non-INRs, so we can understand the imaging that they're looking at, and what they're thinking when they're looking at DSAs, how they're planning their procedures, how they're planning whether it's going to be a stent assisted or balloon assisted coiling or a normal coil, or sort of just getting into the mind of the INRs, which I think will be fascinating. There's a workshop for everybody else who's not a neurosurgeon by vascular neurosurgeons to understand how they make their decisions and what they're thinking about and what their priorities are and where they're coming from. So I think that's also going to be a good one. And there's a condensed Neuro Resus course, which is something I've been involved with for the last few years, which is a sort of neuroemergencies course for everybody involved in neuroemergency. So lots of good workshops, which I think is another big draw, which I think anaesthetists who work anywhere in this area would appreciate. But yeah, anyway, thank you for your support and thank you for your time.
Looking forward to it. No, thanks very much, Oli. Absolute pleasure.
Right, cheers, Andy.
Thank you.